Welcome everybody. I see we have a nice crowd joining us this Monday evening. I'm sitting in Stockholm where it's quite rainy and cold right now, so I think this is a good opportunity to talk a little bit more about robotic surgery. This has been one of my interests for many years, working with many aspects of robotic surgery, and today I'm going to talk a little bit about what we have in terms of evidence for the benefits of robotic surgery and also talk a little bit about cost aspects of of robotics. I just want to be clear that most of the things I will share tonight are personal opinions, unless I will say anything differently. So the title is really Robotic Surgery in Gynecological Oncology. What is the evidence? And I think we'll start off now. Like this probably. So if we look at surgery in general, I think in my opinion, I think robotic surgery merely represents the natural evolution of surgery. So if we go back before the pretty much the 1980s, everything was basically open surgery, laparotomy, and because there was nothing else to compete with laparotomy, perhaps with the exception for vaginal surgery. Then in the 80s, conventional laparoscopy picked up, and the gynecology was one of the leading specialties, developing minimally invasive surgery. And in the late 90s, early 2000s, we saw the introduction of robotic surgery. And I think for me, this represents the evolution of doing something in different ways. And if we look at the current technology, I'm a firm believer that we will see an even more rapid evolution, most likely occurring in the robotic platform. And we can see here we have what's coming out now is the next generation of the Da Vinci platform, the SP single port system. And this is a picture from the ERCAD Institute in Strasbourg, which is a hybrid theater where we can combine advanced imaging with surgery. And I think it's important to keep in mind that the development of novel technologies is a major cost driver. So it doesn't come for free, for sure. I think it's also important to point out that there is no really conflict between conventional or straight stick laparoscopy and robotic surgery. They just represent different tools in the arsenal we have as surgeons to choose from. And nothing is really better than the other one. And you can perform equally well doing a hysterectomy, radical hysterectomy, using both conventional laparoscopy and robotic surgery. And I think robotic surgery, again, is the evolution where we add modern technology to computerize laparoscopy. So when we look at the evidence for robotic surgery, we need to keep in mind again that this is laparoscopy, but it's just a modern evolution, modern development of laparoscopy. So what do we know? What do we have in terms of evidence supporting what we do by minimally invasive surgery? Well, we have the large LAP2 trial from the US published in 2009 by Walker. This was a randomized controlled trial randomizing women with endometrial cancer to either laparoscopy or open surgery. And we have the recently published LACE trial by Andreas Obermeier and co-workers doing the same thing. And these two trials show that complication rates were lower by laparoscopy. And we also have follow-up trials from both the trials showing that survival was similar. So we know from both these trials that minimally invasive surgery is better than open surgery. And we have now two large randomized controlled trials. So we have a level 1 evidence in support of doing minimally invasive surgery. So when we look at robotic surgery, can we expect that traditional outcomes like blood loss or length of stay, complications, and so forth, can we expect them to be superior by robotic surgery compared to laparoscopic surgery? Well, I think that's going to be difficult. And so it's probably going to be difficult to show that robotic surgery is advantageous if we look at these traditional outcomes. And that's mainly because the most adverse outcomes, like ureter damages or infections by laparoscopy, they're quite rare already. And most of our quality indicators, like blood loss or length of stays, they may just be considered proxies for something else, like survival or quality of life. And looking at the data series we have by conventional laparoscopy, most of these indicators or outcomes are already satisfactory. Do we think that we can have a benefit from robotic surgery looking at survival? Well, that's something we can discuss this evening, and I would not expect this. So I think for these emerging technologies or for robotic surgery, I think we need to look at other relevant measurements if we want to prove that robotic surgery is superior. So we need to ask ourselves, what are the true benefits of these technologies? Because if we keep looking at things that we've already managed to bring down to very low levels or satisfactory outcome levels, I think it's going to be very difficult for us to prove that this is better. The next question I think we need to ask ourselves is, could robotic surgery be worse than laparoscopy? This is a very important question because if we want to extrapolate the data from the LAP2 trial and the LACE trial showing that minimally invasive surgery is better than open surgery, we need to make sure that robotic surgery is not worse than laparoscopic surgery. So could it be possibly worse? Well, I guess it could be worse because there's a higher level of technical complexity. We will lack the haptic feedback, so there's no force feedback when we do robotic surgery. The robot is strong, so there's a bit of a risk that we use excessive tissue force when we operate. And it's also a bit of a change in how we work as surgeons. If we look at open surgery or straight stick laparoscopy, that's a type of surgery that you can share with a colleague, and you can do left side, and you can do right side, and you can share a case. If we look at robotic surgery, this is basically done by the consult surgeon, and the consult surgeon controls everything. So it's more solitary, and this may or could potentially affect the outcomes. But I think it's also extremely important, and I will come back to that later, that the learning curve, the initial learning curve, how you define it, if it's 20 or 50 or 100 cases, the learning curve is not the same as inferiority. So we need to be clear when we compare robotic surgery to anything else, like laparoscopy or open surgery. Are we comparing apples and pears? If we compare a surgeon in the initial learning curve, we cannot expect exactly the same outcomes. So this again, this is about solitary surgery, and I think all robotic surgeons will prefer robotic surgery not only because we think it's allows us to do more advanced surgery, but it also is from an ergonomic standpoint beneficial. If we compare with the laparoscopy again, that's something that can be quite strenuous on the back, neck, shoulders, standing in awkward positions for a long duration. So we hope that the position in the console is beneficial from an ergonomic point of view. But I think it's also important to keep in mind that being alone at a console might be more stressful. These are two publications from the past few years just showing a little bit that maybe in contrast to what we believe that prolonged surgery increased fatigue, and the surgeon who experienced the greatest fatigue was the chief surgeon in the robotic protocol. So this is something we need to be aware of. So when we look at evidence-based robotics, another key point here is really to ask ourselves, who do we want to present evidence to? Do we want to present evidence for our patients, to the administrations, to the society, or for ourselves? Here in the right part of this picture, we have this is all the phases when we launch a new drug, like a new anti-cancer drug. So you all know that this is a very, very controlled, meticulous system going through phase 1, 2, 3, 4 before it's even launched on the market. So we need to make sure that it's safe, it has efficacy, and in many cases also that it's cost beneficial. So all these things need to be met before a new drug can be launched on the market. But when it comes to device, like pretty much any surgical device, including the robotic platform, we don't have to have this kind of evidence before anything is launched. We need to make sure, or the manufacturer needs to make sure it's safe. It needs to have a CE mark or a regulatory authority approval, but it doesn't have to have any evidence showing that this is superior to anything else. And when we look at robotic surgery, we know that millions of procedures have already been done in the past almost 20 years since the first launch of the Da Vinci system. Millions of procedures. And we have thousands of systems worldwide. So this creates a bit of an awkward situation where we've been using this platform for so many years, and now we start looking for evidence. So this is another thing we need to ask ourselves. If we end up with outcomes from randomized controlled trials showing that could potentially be worse, are we going to quit robotic surgery or not? So these are some of or pretty much all the randomized controlled trials in gynecology, not only for oncology, but also for benign indications. As you can see, most of these trials are quite small, ranging from about 60 to 122 patients. Most of these are for benign indications, and most of them for hysterectomy, only one for sacrocolpopexy. We have 2 randomized controlled trials for endometrial cancer, and the most recent one was from Karolinska published last year. And they've been comparing to both open surgery, laparoscopic, and vaginal hysterectomy. Looking at different outcomes such as number of nodes, costs, operation time, complications, and they pretty much show that robotic surgery equals laparoscopy in terms of outcomes. So looking at operation time, complications, they're pretty much the same in some trials. Robotic surgery superior, some serious laparoscopy superior. Cost has typically been shown to be more expensive by robotic surgery, but not in all trials. So not very many trials and quite small. This is not from gynecology. This is the roller trial. It's one of the first and largest multi-center randomized controlled trials for rectal cancer. And before I go on with the roller trial and the next trial I'm going to discuss, I just really want to say that David Jane, who was the principal investigator of this trial. I heard him present this abstract last year, and it's truly admirable what he's been doing, and then the entire team of the roller trial. It's very, very difficult to set up a randomized controlled trial for any surgical indication, and I do admire their efforts. But nevertheless, I'm going to criticize this trial because there are a number of things that needs to be discussed in trial in detail. I'm taking this as an example of what happens when you do a surgical trial in a post hoc situation. So even though it's not for gynecology, I think it's still important for us because it's one of the first multicentric randomized control trials. So in this trial, they randomized patients with rectal cancer to laparoscopy and robotic surgery. They included almost 500 patients, 10 countries and 29 sites. And the primary endpoint was a rate of conversions from either laparoscopy, robotic surgery to laparotomy. And the results were that there were no differences in conversion rates. So no difference in conversion rate between the straight stick or conventional laparoscopy and robot-assisted laparoscopy. They observed a longer operation time with robotic surgery, and robotic surgery was more expensive. So in my opinion, if you have a randomized controlled trial with these kind of endpoints, you end up with these outcomes. The conclusion ought to be that we should quit robotic surgery. However, this was not a conclusion in this trial, and I think that was very wise of them. Now, going back to gynecology and gynecologic oncology, and again, I want to commend really the team of the LAC trial, Pedro Ramirez and Andreas Obermeier, for a huge effort to run this trial. It's been running for many, many years. If you haven't heard about the LAC trial, I heard about this trial the first time in 2009, and it's a randomized controlled trial comparing open surgery or minimally invasive surgery, both laparoscopic or robotic surgery for early stage cervical cancer, radical hysterectomy. Now, the LAC trial has not been published yet, but an abstract was presented at the SGO just a few weeks ago, and it has evoked kind of a lot of reactions from our society or from the GYN oncology world. So I think it's worth mentioning this trial because I think the results are quite striking. So this was a multi-center trial. They had 35 sites, and it opened up in 2008 and closed in 2017, so almost 10 years. The plan was to enroll 740 women, and they were able to enroll 631, and they were quite balanced, so almost 320 by minimally invasive surgery, and of them, 45 were robotics. So just a minority, we need to keep in mind, just a minority was robotics, and about 300 open. Median follow-up time was 30 months. So just before we go on to results, is this relevant for this talk to discuss a trial where most of the patients were randomized to laparoscopy? Well, clearly it is relevant because if we want to use the data or the outcomes from the LAP2 trial and the LACE trial, we have taken these as evidence for minimally invasive surgery in general. Well, clearly we need to take these data into account as well. So the results were very, very striking. So they had a recurrence rate in the open arm of only 2.2% versus almost or 7.5% in the lap or robotic arm. Died of disease, only 1% died of disease in the open arm versus 4% in the minimally invasive surgery arm. So again, this abstract has been presented, and Professor Obermeier has been kind enough to share the slides. So I think it's fairly safe for me to show them today as well. So these were the curves, the survival curves for the main endpoint, which was disease-free survival. And as you can see here, this is the open arm, and this is the MIS arm, and there's this very, very large difference. So the hazard ratio is almost 4 for disease-free survival equals to recurrences. That's a big difference. If we look at overall survival, it's looking even worse. So for robotic or laparoscopic surgery, this is the curve, and for the open group, we have the green curve. So as you can see here, the hazard ratios is 6 for death. So the conclusions from this trial, this LAC trial, was that the disease-free survival was inferior for minimally invasive surgery compared to open radical hysterectomy. There was a higher rate of local, regional, and recurrences with laparoscopic or robotic approach. Again, I think if we conduct, initiate, design a trial like this, where the endpoint in this case is survival, and we end up with a result like this, well, then clearly we should have a conclusion saying that we should quit minimally invasive surgery for cervical cancer. So what's going on here? This is, to me, this was a shock. I was just expecting this trial to show that this was similar. It ought to be equal survival. So to me, these are shocking results. And if we combine the results from the LAC trial and the ROLL trial, what's going on? If you look at these two trials, this is a ROLL trial for rectal cancer. This is a LAC trial for cervical cancer. These are the results from the experimental arm. In the ROLL trial, it was robotic surgery. In the LAC trial, it's any kind of minimally invasive surgery. This is the comparator, the gold standard. In the ROLL trial, this was laparoscopic surgery. In the LAC trial, open surgery. These are the main conclusions. So robotic surgery was not better in the ROLL trial, and the MIS was worse in the LAC trial. But the problem is really here, it's not really the outcomes of the experimental arm. The problem is that the excellent performance of the gold standard. So these were the numbers that were expected in these two trials. In the ROLL trial, they expected a conversion rate of 25% in the gold standard in the laparoscopy arm. 25, but ended up with only 12. In the LAC trial, the power calculation was based on a disease-free survival of 90% or 10% recurrences, and they ended up in the open arm of only 2.2%. You can't beat these numbers. So going back and dissecting the ROLL trial, was it a fair game? Well, clearly, this trial, the ROLL trial, was underpowered. If we look at the true outcomes here, we see that we had 12% conversions in the lab group, with only 8% in the robotic group. So it's underpowered. There's a difference here between the conversion rate in favor of robotic surgery. So the sample size calculation was based on all results from the MRC Classic from 2005, which had a conversion rate of 25 to 35%. And more importantly, we have this differences in experience. We have a learning curve bias. So experience from 28 robotic cases for rectal cancer had the same results as experience from more than 90 laparoscopic cases. Robotic surgery was superior for male patients, and maybe we might have seen a different outcome if the trial had been focusing on new platforms like the XI. And this is, I cannot understand, why would robotic surgery take longer time than traditional laparoscopic surgery? It does not make any sense. The only difference is really the docking. That's the only thing that could take more time, and that's a 2-minute thing. So the only plausible explanation for this is the learning curve bias. So they have tried to model the experience. So here we have the odds ratio for conversions in the roller trial. So the odds ratio here is 1. That's equals to 91 laparoscopic. There's a median number of experience that the laparoscopic surgeons had. So here, 28 is the cutting point here. If they have been using the same number of robotic cases for in the experience, we would have a much lower conversion rate. So we've been comparing two different things again, comparing novice robotic surgeons with experienced laparoscopic surgeons. These are some other data showing something completely different. This is from Seaman in 2009, looking at conversion rate between robotic surgery and laparoscopic surgery in relation to BMI. And as we can see here, we have at a BMI of 40, we have a conversion rate of about 10% for robotic surgery and a conversion rate of 35% by laparoscopic surgery. This is a trial from Sweden. It's a population-based registry trial study looking at evaluating surgery in newly diagnosed uterine cancer. If we look at robotic surgery compared to a straight stick or conventional laparoscopic surgery, we have a conversion rate here. 1.6% by robotic surgery, 13 by laparoscopic surgery. So these are the numbers that may be relevant for us in GYN oncology. All these things showing that the conversion rate is actually lower. So the LAC trial again, we go back to the LAC trial. So we have now data from a randomized controlled trial showing that minimally invasive surgery seems to be dangerous for patients with early cervical cancer. So should we go back to laparotomy? So here we have the results from the LAC trial, not published yet. Just want to remind you of this. We had 7.5% recurrence rate in the minimally invasive arm versus 2.2 in the open arm. These are some other studies. They're not randomized. They're retrospective analysis, case series. But as you can see, we have quite a large number. In total, more than 700 women operated by robotic surgery. And in this case, there's almost 700 patients operated with open surgery. And as you can see here, we have recurrence rates at around 8 to 13% by robotic surgery. All these are robotic surgery. And we have pretty much the same number by open surgery. If we just combine all these trials here in the last row, we have 72 events, 72 recurrences that equals to 10% recurrence rate, and in the open are 11. So no difference. So these are what's been going on for the past 10 years in both Europe, and these are American data. So these are the actual outcomes from 10 years of robotic surgery comparing to open surgery. Obviously, these are not randomized data, but nevertheless, they do show what's been going on. And there is no difference. So if we quit robotic surgery or laparoscopic surgery for radical hysterectomy, we will not be seeing these numbers. We will be seeing these numbers because this is what we had before we started with robotic surgery, laparoscopic surgery. So we will be seeing the same recurrence rates. These are just very preliminary, immature data from It's a population-based registry study from Sweden. We have all patients treated surgically treated from 2011 to 2018 for early stage cervical cancer. So as you can see, there are more than 1,000 patients operated by either open surgery or robotic surgery for the past 7 years in Sweden. And as you can see from these curves, it may not be super clear, but we have a blue curve for robotic surgery, a yellow curve for open surgery, and they're just exactly the same. 5-year overall survival was exactly the same. We don't have the disease-free survival, but I would be very, very surprised if there was a difference, since we have the exact same overall survival. Clearly, not randomized data, but showing reality. So the LAC trial, do we have any limitations? Well, I think we need to see the publication first. We don't know when they will publish these data. There was an early termination because they had problems to recruit patients. There were 35 sites, and they were able to recruit 70 patients a year. That's a quite low number, especially if you consider the number of sites. We don't know anything about learning curve bias, but clearly we're comparing the gold standard. We've been doing open radical hysterectomy since Ernst Wertheim, so that's more than 100 years. We'll be doing laparoscopic or robotic radical hysterectomy when they started this trial for about 10 years. So we cannot exclude the risk of a learning curve bias. Maybe we're also looking at the premature analysis of the data because only 40% of the data were complete when they published the abstracts. I think this is so important right now because if the data from the LAC trial hold up, well then clearly the open surgeons in the LAC trial, they need to teach us all how to perform a radical hysterectomy, because I don't think anyone has these numbers. 2.2% recurrence rate and only 1% dying from the disease in stage 1B1. That's essentially the same as curing the disease. So I think we need to wait a little bit. Definitely don't think this is the end of minimally invasive surgery for cervical cancer. We need to see the full data before we can draw any firm conclusions. Right. This is just to show the difficulties in performing randomized controlled trials. And as most of you know, we had a quite famous trial, the ERTC trial for a neoadjuvant chemotherapy or primary debulking surgery for ovarian cancer, completely different disease, and has nothing to do with robotic surgery. But as you might remember, the main outcome showed that neoadjuvant chemotherapy was the same survival as primary debulking surgery. But again, as you all know, this trial has been heavily criticized for selection bias. There's been a poor quality assessment for surgical quality. And maybe this trial showed something completely different. So this has led to a new trial called the TRUST trial. And in this trial, which is going to be the ultimate trial to really give the final answer on this question, the TRUST trial committee will only have selected sites, a very detailed selection criteria, and a very detailed quality assessment for surgical proficiency. And why am I mentioning this? Well, maybe we're going to end up with the same conclusion from the LAC trial. We need a new trial after this. We don't know yet. We need to see the publication. So let's just spend the few last minutes on the cost and robotic surgery, because this is one of the big issues. It used to be perhaps the biggest issue before the LAC trial data were published. And there was a consensus statement from the SGO a couple of years ago where robotic surgery was found to be more expensive than laparoscopy or open surgery. The funny thing is that doesn't seem to apply to Sweden, because we have now 5 studies from Sweden all showing that the cost for robotic surgery is the same or lower than open, or in some cases even for laparoscopy. So something is also going on here when we have a completely different cost scenario for robotic surgery. And I think it's really worth stressing that cost effectiveness when it comes to novel technologies like the Da Vinci platform, it depends very heavily on the healthcare system, on the reimbursement system, on the proportion of insurance-based medicine and so forth. So all the things that we do to reduce costs for robotic surgery may not be applicable for all healthcare systems. This is a randomized controlled trial that we conducted at Karolinska, and we published this last year. The secondary endpoint was cost outcomes, where we looked at the cost for open versus robotic surgery for comprehensive staging of endometrial cancer, including pelvic and infrarenal aortic lymphadenectomy. So in this randomized controlled trial, we saw that the cost for open surgery was higher than for robotic surgery. And this equals to a mean saving for us in Sweden at Karolinska of about $1,500 per case. So every time we were forced to do an open case for different reasons, the hospital would be losing $1,500 per case. So how is this possible? This is just to illustrate the effects of robot-assisted surgery at Karolinska. This is the pre-robotic era for endometrial cancer in Stockholm, where we had a very low proportion of laparoscopic surgery or minimally invasive surgery, only about 15%, while now, 2015, it's almost up to 85-90%. This equals to a lot of hospital days. Now, length of stay may not necessarily equate to a lower cost, but clearly spending for the patient spending less time in the hospital, that's a no-brainer. This is a good thing. This is a good thing for the patient, and it has to be good for the society and for the hospitals. So we've been working in Karolinska, and I've been lecturing about this for many years now, to work on over efficiency. Because the worst thing we can do when we invest in novel technologies like the Da Vinci platform is not using it. That's going to be the most expensive things we can do. So what is our efficiency? Well, that's the efficient use of equipment, theaters, and staff, adapting to changes in volume and complexity in your surgical panorama, to define the surgical program, and to track our outcomes. So cost-effective implementation of novel technologies. So this is a quite famous now curve for the cost of robotic surgery in relation to the number of cases you do per year. So there's a bit of a cutoff here at about 100 cases per year. If we do less than 100 cases per system in a year, it's going to be very difficult to defend the use of robotic surgery because the cost will be very high. So over efficiency, that's going to reduce the cost of robotic surgery. It's going to reduce the waiting time for our patients. We will spend more time in the console as surgeons, and it's going to improve our team building. And I need to stress this really strongly, because it's not only about the surgeon. Surgeons tend to focus on console time, surgical outcomes. This is a turnover time. This is the turnover time in the theater at Karolinska. When we started with robotic surgery in 2009, we had a turnover time of 2.5 hours between two cases. So we worked actively to reduce turnover time, which has led to a turnover time of about 1 hour. This will allow us to go from 1 or 2 cases per day to 5 or 6 cases per day. And this is one of the most cost-saving measures that can be done. So again, surgeons, if we look at over efficiency, we have several steps. We have port placement, docking, and then later on the undocking. We have console time, and then we have the change time or turnover time. So this is going to be the time we spend from the first patient to the second patient. The surgeons, they tend to focus on console time. These are data from an actual hospital in Sweden. So this is looking at their first 50 cases, these here, and compared to their second 50 cases. So when I started proctoring this hospital, they had long docking times, they had long consult times, they had long turnover times. When I came back to proctor again, the consult time was reduced significantly. So this is what happens when surgeons get proficient. And I'll be surprised if consult time doesn't drop after a while. But here you can see that the docking time, basically nothing happened. So they weren't really interested, or they hadn't been focusing on docking the system or undocking. And especially here, the change time, turnover time. Here, so we really can save time if we want to improve our turnover and efficiency in the theater. We need to look at the whole picture. Surgeons tend to focus on the consult time, and we need to look at docking. These are the data from Karolinska showing our consult times that were quite high in the beginning, dropped down to 40-45 minutes for a simple hysterectomy or for a low-risk endometrial cancer. We had docking times in the beginning of an hour, and they should be under 15 minutes from the first incision until we can sit down on the console. And turnover from the time when we place the last suture until we can start with the second patient, turnover time has to go down from 2.5 hours if we want to save money and make this cost efficiently. So going back again to evidence-based robotics, are we there yet? Well, we know that laparoscopy is better than open surgery, at least for endometrial cancer. This is something I have to add now after the LAC trial data. So we need to wait for the final results there, but until then we can only say this for endometrial cancer. We know that robot-assisted surgeries, modern laparoscopies, we can extrapolate the data from laparoscopy to robot-assisted surgery. We know from the roller trial that the learning curve for robotic surgery is shorter than from laparoscopy. We know also from the roller trial and from many other trials that conversions are fewer by robotics than lap. And we know from the ROSEC, the Swedish ROSEC trial, and from many other Swedish trials or studies that cost effectiveness can be achieved. This is going to be easier for complex surgery, for high volumes, but simple surgery, like simple hysterectomies or myomectomies or whatever, they can be done cost effectively if you have excess capacity in your system. Thank you very much for your attention, and I'll be happy to take any questions.
The first question was, is there any evidence of superiority of Da Vinci procedure versus laparoscopy in same-day laparoscopic surgery for hysterectomy? So I think it's around outpatient programs.
Right. Yeah, I think this is a very relevant and interesting question. I think this is where we're heading in the future to do more same-day discharge. So if we look at our outcomes at Karolinska, we're now down to a mean length of stay for one day. So it's not easy to bring it down even lower, but I think it's definitely possible to do outpatient or same-day discharge. There's no evidence so far. If we by evidence mean any randomized controlled trials, whether robotic surgery will be superior to laparoscopic surgery in terms of same-day discharge, I think it's too early to know right now. We need to have more data coming in. So, but I think, I mean, looking at single-site surgery for robotic surgery, we may have an option for, especially for low-risk endometrial cancer or for benign indications.
Thank you. So the next question was, are you able to decrease the intra-abdominal pressure when you work with Da Vinci? I could see an important benefit for endometrial patients and high BMI patients. So,
Yeah, thank you. This is another. I think it's a very good question, and this is actually one of the benefits of robotic surgery that we tend to overlook. So if we compare with laparoscopic surgery, we cannot rely on our instruments to lift up the abdominal wall, while by robotics, the abdominal wall can really hang on the camera port, which means that we can reduce the intra-abdominal pressure. So in obese patients, we normally go down from 12 to 7, and this will still allow us to do pelvic surgery without any major problems. So I think it's one of the things that we need to have a good discussions with our anesthesiologists. If they feel that they have problems to ventilate the patients, we can start by going down in pressure instead of reversing the Trendelenburg, which is more critical for a surgery than having a high pressure. So yes, I think it's definitely possible to go down even to 7 or even lower if you have the camera port correctly positioned with a good traction in the abdominal wall.
so we have a question from Germany, Dr. Alkatut. Do you change counseling of your patients after the lack data?
Well, yeah, I'm operating one patient tomorrow with a cervical cancer, and I have to be honest, I haven't. And the reason for this is twofold, I think. We haven't seen the publication yet. I think that's critical. We can't make this big change based on abstract because we need to look at the data. Do we have a learning curve bias? And are the data really mature to be analyzed? And the second thing is, again, I cannot believe that we by abandoning minimally invasive surgery would have the results as they were seen in the open arm from the LAC trial with 2.2% recurrence rates. We need to keep in mind that 2.2% recurrence rate, that's lower than the largest trachelectomy series with a low risk cervical cancer that are node negative. These are even lower number than them. So I have a hard time to really accept the data from the LAC trial, and I don't think we have to until this trial is actually published.
Okay. Now, is a training of a fellow an issue for your robotic program?
Yes. That's a short answer. It depends on if it's a fellow or it's a registrar. Where in training are we? And this could be another lecture. So I think it's really important to adapt the number of consult surgeons you have in your program according to your volume. This was discussed in a debate a couple of years ago, and the question was, how many cases do you need to do per year as a consult surgeon? And most of us agreed like 40, 50 cases per year. So if you do 100 cases a year, you should be at least 2 or 3 consult surgeons. Now, can you train a fellow then? Well, it's possible, but in my institution, I've been training fellows if I see an increase in volume. So when we passed 150 cases, I trained a new fellow. When we passed 200 cases, I trained one more. So now we're 4 or 5 consult surgeons. Because the critical thing here is if we train fellows, we need to give them the opportunity to do console work after that. Otherwise, it's quite useless. If you look at the really problematic situation, that's for the registrars or for the juniors. Because if we go back to the straight stick or conventional lap era, they could more or less assist us during a laparoscopic hysterectomy. Since we're doing more and more of the surgery by ourselves as console surgeons, where we control not only the camera, but also the third arm or the retractor, we don't need an assistant anymore. So this is a bit of a problem. And I think it's really important to define your program. How many cases do you have? How many fellows do you need? In the big institutions like Karolinska, where we do almost 1,000 cases per year, clearly we can have fellowship programs because we can alternate between gynecology and urology and colorectal. But otherwise, this might be a problem.
Thank you. Do you think the XI model with its new nimble arms and less collisions between arms would affect many factors such as conversion rate and performing upper abdomen procedures in gynecology oncology cases?
Yes, well, I think it would have affected the roller trial, maybe. I think the conversion rate was really nice in the roller trial with only 8% conversions in robotic arms. So maybe it's not possible in rectal cancer to have an even lower number, but maybe. And for gynecology, we don't have very many conversions. In most studies that have been published, the conversion rate is quite low. So I'm not sure that the XI will bring any benefits in terms of conversions. However, there might be other benefits using the XI for gynecology. And I think one of the main benefits could be for comprehensive staging, including the aortic lymphadenectomy. So, and I have to be honest, I have not been working that much with the XI because it only came a couple of months to our hospital. But we're building up our experience. I've been working with it in other circumstances. So I do think it has benefits in terms of the parotics. For pelvic surgery, I think you can stick with the SI and be happy if you have one. Don't be sorry if you have an SI. You can do marvelous things with the SI.
So there is a question related more to anesthesia. Do you know the number of endotracheal cannula which you use? The surgeon asking the question said he had problems with high intra-abdominal pressures, but the anesthesiologist started to use cannula number 8 instead of 7, and it improved significantly.
Okay. Okay. Well, that's the first time I heard that, so that's interesting. I haven't heard that. I think it's also a bit of a training or experience by the anesthesiologist. So we have so many patients at our institution, and they gain so much experience. So we rarely, and I say very rarely, have any problems with the ventilation of the patients. Even if we have high BMI patients or elderly patients, they seem to manage quite well anyway. But the first thing we do is just to reduce the intra-abdominal pressure. And I think we have done in gynecology almost 2,000 cases now. And I can remember once that we had reversed Trendelenburg, maybe
Okay.
2 times.
Now, what is your input about single port robotics or your view about?
Yeah, single site robotics. Well, I think we're looking forward to the Da Vinci SP, the single port system. And maybe we'll see it this year or maybe next year. So that's going to be that might be a game changer. I think that's going to be something that's we look forward to see. I think, in my opinion, as an oncologist, I think the place of single site surgery, as for now, it's difficult for me to see the benefits of this because basically you do something that's really great with a multi-port system. I think it's absolutely working fantastic with the Da Vinci platform, either with the SI, the XI, with the multi-port. It's really been a game changer for us. And going back a bit to making it more complicated, it's difficult for me to see the benefit because most of our patients are elderly, especially with endometrial cancer. I don't think it matters to them if they have 4 scars, so you can do 3 scars or 3-port multi-port. For cervical cancer, it could potentially be a benefit, but really, for most, at least of my patients, their top priority is to get cured. So we don't do single site surgery for oncology. And I do think it's the future. I think it's just a natural step. It's a natural evolution. But so far, I think we need to see the SP in that case.
And the final question would be, what would you recommend to emphasize to the CEO of an hospital if you would have no Da Vinci system yet?
Well, that's another very good question. I think it depends on how you work today. Do you do mainly open surgery or laparoscopic surgery? And you need to look at your outcomes. Um, and so that's one thing. You need to look at your case mix. Do you have mainly advanced surgery, or do you have a mix of advanced or less advanced surgery? Are you planning to do sentinel node mapping, use the Firefly, which is included in both the SI and the XI system? All these things. So you need to look where do you come from? So in my case, we came from open surgery. So it was quite simple to convince the CEO that this would reduce the length of stay and we could do things that we couldn't do by open surgery. If you come from advanced laparoscopic surgery, this might be more difficult to convince. But I do think it's a lot easier to do a fast track or a over efficiency system using the Da Vinci platform compared to straight stick laparoscopy. And I also think that you should stress the fact that the learning curve for fellows and for surgeons that come from laparoscopy or open surgery is shorter by robotic surgery. And clearly, we can look at the cost side. And so we have data from a randomized trial showing that it's cost beneficial to use robotic surgery.